Hello, my name is Intius and my partner's name is Travis, and we're here to present a research article by Dr. Subham Argwal from Rosalind Franklin University of Medicine and Science about COVID's effect on the endocrine system. COVID has become a part of our everyday lives now, unfortunately, and it does not look to be going away anytime soon. With that being said, there are still many of us that are unaware of the impact that COVID can have on our health, especially on our endocrine system. We will be talking about the impact of SARS coronavirus and SARS coronavirus 2 has had or may have on our endocrine system throughout this presentation. Some of these areas we will be talking about in this presentation are the thyroid, adrenal glands, pancreas, pituitary, and gonads.
Research on the relationship between COVID and the thyroid has been rapidly increasing since the outbreak in March 2020. COVID infects host cells through ACE2 receptors found in the lungs. We have learned about the RAS pathway and angiotensin converting enzymes, or ACE. ACE metabolizes angiotensin 1 into angiotensin 2. ACE2 differs from ACE because it metabolizes angiotensin 2 into angiotensin 1 through 7, and this helps regulate the RAS pathway. ACE2 receptors are expressed throughout the body, but are more concentrated in the thyroid than the lungs. This means the virus can spread more rapidly and do more damage to thyroid cells as well as the rest of the body. Specifically, follicular and parafollicular thyroid cells are damaged, and this is a sign for researchers to rule out underlying thyroid illnesses and that the virus is indeed damaging the thyroid. This damage can lead to hypothyroidism, which has been commonly found in COVID patients. TSH, T3, and T4 levels decreased in many COVID patients depending on the phase of illness. Researchers found that of 1,237 patients tested, T4 levels dropped in 46% of patients in the acute phase of illness and in 38% of recovering patients. T3 levels decreased in 94% of patients in the acute phase and in 90% of recovering patients. The severity of the infection has been found to correlate with how low T3 levels drop, so T3 can be used as an indicator for how critical the patient's condition is. This is why patients with thyroid disorders and the elderly are at an even greater risk to COVID. Low T3 and T4 causes calcitonin deficiency, which leads to osteonecrosis or death of bone tissue, and this has been commonly found among recovering COVID patients.
The adrenal gland is another area where COVID-19 may have an effect on. The adrenal gland sits on top of each kidney and consists of the adrenal cortex and the adrenal medulla. The adrenal cortex secretes hormones such as aldosterone, cortisol, and DHEA. Aldosterone is responsible for regulating water and salt levels. Cortisol is known as a stress hormone but also plays roles in the metabolism and our immune system. DHEA is a precursor for testosterone and dihydrotestosterone. The adrenal medulla secretes epinephrine and some of norepinephrine. Both of these hormones are involved in our fight or flight response. SARS-CoV genome sequence has been detected in the cytoplasm of numerous neurons in the hypothalamus and cortex. This can directly affect the hypothalamus, leading to hypothalamic pituitary dysfunction. Patients who have recovered from SARS-CoV were found to have hypocortisolism. ACTH levels were also found to be low. This is important because ACTH is what activates the adrenal cortex to take in cholesterol and convert it to progesterone, which is the rate-limiting step for steroidogenesis. So this means that ACTH levels are linked to cortisol levels. Findings from SARS-CoV and SARS-CoV-2 patients suggest actively monitoring biochemical changes like serum cortisol and ACTH. Should these biochemical changes go unnoticed, it may complicate post-SARS recovery. There has been data to support that the coronavirus affects our pancreas, which leads to diabetes. Before I get into how coronavirus affects our pancreas, let me inform you on the importance of pancreas in our endocrine system. Our pancreas is very important for regulating our glucose levels. Pancreas contains islet cells, which play a huge role in our endocrine system. These islet cells could be beta cells and alpha cells or delta cells. Alpha cells secrete glucagon and delta cells secrete somatostatin. Beta cells secrete insulin, which is a big factor in diabetes. Insulin's main function is to promote the uptake of glucose into different locations of the body, such as the liver, in muscles, and adipose tissue. Glucose is stored in different forms depending on the location of the body. For example, the liver and muscles is stored as glycogen, and in adipose tissue it is stored as triglyceride. The goal of insulin is to lower glucose levels in the blood. Okay, so if our beta cells are not functioning right, this is what can lead us to diabetes. There is type 1 and type 2 diabetes. Type 1 diabetes is the autoimmune disorder which results in non-functioning beta cells leading to very low levels of insulin, which leads to hyperglycemia. Diabetes type 2 is when your beta cells are not completely destroyed, but still not functioning properly enough to where it leads to an insufficient amount of insulin secretion. SARS-CoV viruses may damage pancreatic islet cells and cause temporary diabetes. The damage is islet cells, mainly beta cells, would cause you to be in a temporary insulin-dependent state. According to Dr. Subham Agarwal, new diabetes developed in SARS-CoV patients who had no previous diabetes and received no steroid treatment during illness. Patients with diabetes may present with milder symptoms initially, but they were at higher risk of rapid progression to severe pneumonia. SARS-CoV-2 infections in patients with diabetes might trigger stress conditions and increase secretion of hyperglycemic hormones, such as glucocorticoids and catecholamines, resulting in elevated blood glucose. So with the potential impairment of beta cells and promotion of hyperglycemic conditions, this is how COVID-19 can affect the pancreas to where it can cause the conditions for diabetes. In addition, pre-existing diabetes may be considered a risk factor for poorer outcomes of SARS-CoV-2 pneumonia.
Men are twice as susceptible and have a higher fatality rate to COVID than females. This is because of the difference in sex hormones and chromosomes. Male gonads have high levels of ACE2 receptors throughout the testicular tissue. ACE2 receptors regulate sperm and steroid production. Leydig, Seroli, and seminiferous ducts can all be infected by the virus, and this causes a drop in sperm production and steroid genesis. Overall reproductive function is greatly reduced in many male COVID patients. Testosterone has also been found to drop commonly. Low testosterone and androgen levels reduce the immunity of infection in the lungs. Testosterone levels revert to normal slowly after recovery. Studies have found LH to increase in men infected by COVID, but the ratio between LH and testosterone is very high. COVID infections in the female gonads have not been reported to this day, and the explanation is still being researched. Having higher levels of estrogen and progesterone allows higher anti-inflammatory responses, and this prevents the spread of COVID since the virus uses inflammation to spread more easily. Estradiol and progesterone suppresses pro-inflammation and stimulates antibody, T helper cells, and T cell production. Estrogen is being studied as a possible treatment to COVID. X chromosomes are the source of immune-related genes, and this is why women have a higher general immune system than men. COVID affects our endocrine system through our thyroid, adrenal glands, pancreas, and gonads, and a lot of research is still being carried out. We are slowly but surely learning more and more about the virus and how we can prevent infections, as well as conditions that derive from the virus.